David. I forgot where I was there. We need microphones here. And obviously, thank you, everybody, for coming along to the St George's Centre, a different venue from the one originally advertised. As people probably know, we've been hit by RAC at Gun Wharf, and the surveys and possible repairs are taking place. So we're back here. So, the acoustics are not great. So I hope that today's meeting is going to be a really interesting one. I'm very pleased to welcome Jonathan Shaw, the Strategic Director of Kent Further Education, and colleagues from colleges who have come along to kindly support him on an item that I've been particularly interested for the board to look at, and that is assistive technology. A new and hopefully modern way of helping people remain independent, a potential generator of all kinds of jobs from technology right through to social care in Medway. And so it's a little bit of a departure for the things that the board normally does, but that's our first item. I'd also like to welcome Claire from Kindy, who currently is the council's supplier of assistive technology. So we'll be very pleased to hear anything that you've got to say, Claire. You don't have to be a member to join in the debate. So with that, I'm going to move to the agenda. And I think we've got a couple of apologies for absence, haven't we, Stephanie?
Yes, we have. We have apologies for absence from Donna Marriott, Jackie Brown, Paul Bentley, but Vincent's in attendance in his absence. We also have apologies for absence from Jane Howard. Claire is in attendance in her absence. I have apologies from Kent Local Medical Committee and Adrian Richardson.
I should have turned my mic off so you could hear.
And also Councillor Price.
And thank you to substitutes. Very happy from partner organisations always on this board to see a substitute. I'd much rather the information got back to the organisation than not have anyone here at all. And as it isn't essentially, as it's not a committee only of Medway Council, it always makes sense to do that. So very pleased that you're able to come along in Jane's place, Claire, and pleased to see other people from MVA if that is a necessity in the future. Okay, so I'm going to ask everyone to approve the record of the meeting that was held on the 7th of September. If everybody that was here is happy to do that, I'm happy with that record. Okay, thank you, Councillor Hackwell. So that record of the meeting is approved. I don't have any urgent matters by special circumstance. I don't think, Steph, we've been... So I'm going to move on to, are there any declarations of disclosable pecuniary interests or other significant interests, please? Yes, Councillor Hackwell.
Just as normal, I just like to declare my wife is a public governor of Medway Hospital.
Okay. On to our first item. The Local Skills Improvement Fund, Digital Skills and Innovation in Health and Social Care. So we've got a proposal. And I'll be interested, Jonathan, if you'd like to take the lead on that.
Thank you, Chair. Good afternoon, everyone, and thank you very much for inviting us. If I introduce the team, then explain what we're going to present. So first of all, I'm Jonathan Shaw. I'm the Strategic Director for Kent Further Education, and that role means that I cover the three different colleges across Kent and Medway. And part of my role is to bring people together, bring the colleges together to work with key stakeholders such as yourself. On my far left, Robert McLaren, who's the Director of Policy at Policy Connect, which is a cross-party think tank who specialise in assistive technology. And then on my first left, Lindsay Biggs, who's the Executive Director for East Kent Colleges Group, and then my colleague Claire Brown, who's the Director of Curriculum, specialising in digital and social care at Mid-Kent College. If we go to the next slide, please. So what we'd like to talk to you about is, first of all, give you some national policy context. As you said, Chair, it might not appear, assistive technology, as one of the issues that this organisation talks about particularly, but it has an impact on social care, and we know that social care has an impact on health, both in terms of acute health and public health as well. So as we see those sort of two areas, coming together, I think that hopefully at the end of this presentation, you'll appreciate that assistive technology has something to offer.
For a minute, please.
Just to make you all aware, the presentation that Jonathan's going through is an updated one, so it's not the same that's been published on the website, just in case you're looking through and trying to follow through on the website. This is an updated presentation.
Okay, thank you very much. Thank you. So we'll talk about the national policy context. Robert will refer to that. Then we'll look at local delivery, which Lindsay and Claire will talk about. We've got some money. We've won some money from the government, so this isn't just about sort of hoping, not wishing. This is about doing, and we'll need everyone around this table to be involved in that. And because it's a project over a couple of years, and it's on scale that goes across Kent and Medway, we've got the opportunity to do some research and learn what works in terms of equipping the workforce, both the new workforce coming in our colleges and the existing workforce as well, so they've got the skills and the ability to be able to use assistive technology to help people live independent lives. We know that's a crucial thing about technology, is that the people on the ground have got to be able to be equipped with it. And we think as well, equipping people working in social care will provide them with new avenues in terms of career and make it attractive. And we know that there's a shortfall in people coming into the profession, which has an impact, say, right across our health economy. So those are the 3 points that we like to cover. So to help colleagues, we'll begin with some national context, and I'll hand over to my colleague, Robert McLaren. Thank you.
Hello, everyone. Thank you very much.
Oh, forget that one. Skip that one. I've covered that.
Great. Well, thank you all. As Jonathan said, I'm Director of Policy at Policy Connect, and we're a cross-party think tank founded in the mid-90s by a Conservative and a Labour politician. We focus on a range of different areas. I mean, the ones that are most relevant for this topic is, of course, health policy, education and skills, technology and accessibility, and we're unusual among think tanks in having a real specialism in assistive and accessible technology, or sort of ATEC for short. So this is the team within Policy Connect that works on that. I came into policy through looking at ATEC policy. It's my particular area of passion. And with me in the team is Shamima Akhtar and my colleague Clive Gilbert, who in particular leads on our work on care and independent living. Clive is a member of the Department for Health and Social Care's Digital Care Advisory Group. He's also a patient advocate on the NHS Environmental Controls Group. And all three of us actually use ATEC ourselves. Okay, so our work is separated into sort of two streams. One is we support the all-party parliamentary group for assistive technology, of which, of course, Lord Blunkett is a member, which holds meetings in Parliament to raise the profile of ATEC within Parliament on a national basis. And we also run what we call the ATEC Policy Lab, which is where we hold more kind of workshop style, slightly more wonky and in-depth conversations with specialists to develop new policy ideas. And so there you see the cover of our most recent report from the ATEC Policy Lab, and that was looking at what we're talking about today, which is upskilling frontline professionals. And we were pleased to see that both the recommendations in that report were taken up by the government in its consultation on Disability Action Plan. So that consultation asked people about whether or not those proposals that we'd made were right for the Disability Action Plan. And the fact that there is such a plan, which is a cross-departmental plan, and that it includes assistive and accessible technology, gives an indication, I think, of how much the ATEC agenda has taken shape within national policy. Oh, sure. We have the same problems in our meetings in parliaments. It's thank you. I'm happy to continue on. That's the last slide we got to. Yeah, perfect. Yeah, so I think just finally on that point, just to note really that, the trend in disability policy has been to try to look across departments. We had obviously the National Disability Strategy in 2021, and towards the end of this year or early next year will be a Disability Action Plan. And we've used both of those as ways to get assistive and accessible tech looked at as a cross-departmental priority. When it comes to smart homes, independent living and care in particular, our work has centered around this report, Smarter Homes for Independent Living, which was chaired by Sir Paul Carter and authored by my colleague Clive Gilbert. And that's really the basis from which we work on this topic. And in the next slide we see a number of recommendations that the report made, looking at things like co-production of procurement and programs to do with ATEC with disabled and older people, ideas about creating standards for the safe and effective use of technology, and most critically for today's discussion, recommendations on training and awareness. And then one of our recommendations has already been formally accepted by the government, which was fantastic to see. So we looked at the Disabled Facilities Grant, which is a grant that people can use to make adaptations to their home. It's been around for a long time and didn't really explicitly include technology within it. And Clive's report showed how, in fact, it could be used under the existing legislation to implement smart home technologies for greater accessibility. That really accessibility of a home has sort of changed what it means in the digital age. And that was taken up so that new national guidance has been provided for the Disabled Facilities Grant, which used Clive's briefing into that guidance to encourage local authorities to make use of the grant to help people with tech adaptations. And really we've seen, since the report, just a growing interest in technology within the care sector. So, for example, the work the work on the Disabled Facilities Grant is a great example of that, a long-standing program that's sort of been refreshed and updated for the digital age. The Lords Select Committee also held an inquiry on social care. My colleague Clive gave oral evidence to that inquiry, and it really focused on how technology plays into our ability to make social care genuinely aspirational, so that it's not always just about keeping people out of hospital, but actually about enabling people to live the lifestyles that they want and live more independently. And I think increasingly technology is being seen as critical to that new vision of social care. And following the government's Care White Paper, just about every initiative that they've spun off from that programme since has made a really significant role for technology, and particularly upskilling the workforce in terms of technology. I think it's worth saying here at this point that a lot of the focus on care and tech to date has been on digitisation of care records. But what we're starting to see through our advocacy and others is expanding that conversation, so that as well as being about, if you like, that back-end tech, more and more people are seeing the possibilities of those who use care themselves being the people who are using the technology. And my colleague Clive talked to the Select Committee about not just doing tech to people, but putting it in people's hands so that they can make the use of it that they want. One of the things that we're really interested in, and there's been a focus of our policy engagement since the report, is how can we take the various aspects of good practice that we saw in the report, or some of the funding that the government has put in place to encourage uptake of digital tools within care. How can we make that really standard practice across the country? And I think one of the things that we've seen in this area is that there has been a tendency to focus projects around a particular piece of tech. And so we get a pilot that is a kind of a proof of concept of such and such a robot or device or something like that. And it can produce really interesting results, but then in many cases it doesn't get taken up beyond that. It might be because the technology is quite expensive, it might just be because it's quite narrow, it might be just because all the effort went into using it and trialing it, and there was little left over to really tell that story beyond the small area in which it was tried out. And though we'll talk about this a bit more, I think that instead of thinking about we're going to prove, the effectiveness of this bit of kit, if we think of initiatives in a way that's to some extent more technology agnostic and open to technology developing over the years, and we make that the focus, we make skills and confidence and the kind of infrastructure around the use of tech, if that becomes the focus, that's much more scalable, much more sellable, if you like, to other areas and to national policymakers. And we do that through the partnerships that we form with people within the sector. So I mentioned the ATEC Policy Lab. That's a partnership with Bournemouth University, who have a research specialism in ATEC, and the ACE Centre, who are a leading national ATEC charity. But we also, through the course of our work, have worked closely with CEDIA, who are a professional body of smart home installers, and they've taken an interest in the care and independent living part. So it's not just massive TV screens for the rich and bored, but seeing this as a new and exciting area. Tech companies like NRS Healthcare, and at party conferences we work with the Social Care Institute for Excellence to put on roundtables on ATEC and care at Lib Dem, Conservative and Labour conferences. So we, through this process, have become really embedded in those aspects of the sector, and really want to seize on this kind of moment where I think national policymakers see technology as vital for transforming social care, but are going to need examples of local excellence to draw from in order to make that a reality. So thank you very much.
My turn.
Yep.
Is that okay? Can you hear me? Oh, there we go. I'm echoing now. Good afternoon, everybody. Thank you again for this opportunity for Claire and I to present to you about what we think is a very exciting project. goes without saying, really, doesn't it, that health and social care is a huge priority, both regionally and nationally. So when the opportunity came up for us to develop a bid that kind of addressed the critical workforce needs, we jumped at the chance, didn't we? Sorry, next slide, please. While East Kent College Group are leading on this strand, I think it's really important for everybody to note that it is actually a Kent-wide project. So Mid-Kent and North Kent colleges are also heavily involved and also significantly benefiting from its aims and objectives, which I'll come on to describe in a little bit more detail in a minute. You'll all be very conversant with the challenges that exist within the sector, so I don't propose to insult anyone's intelligence sitting around this table. We talk a lot about recruitment and retention of staff within the sector, but also the burden on all aspects of the service. So when we were building up the scope and scale of the project, we were really keen to develop one that sought to address the challenges of both attracting people to enter the workforce, and something that colleagues have already touched upon this afternoon, by enabling them to understand the opportunities that exist within the workforce, but also align with the digital transformation that we know is already underway. So this isn't about replicating things that are already in existence. We've spent a lot of time developing the bid to make sure that we are complementing the work that is already in existence. We've secured around £192,000 in revenue funding and around £700,000 in capital funding. There's some challenges around spending some of that by March 2024. The DfE always likes us to kind of galvanise really quickly. We were confident with the scale and the scope of the bid because we'd done so much consultation with people within the sector, both within independent care providers, ICB, CEDA, that Robert talks about, that we thought the topic in which we were kind of, and the challenge that we wanted to kind of address would be successful. So we've already done a lot of work behind the scenes to make sure we can be spurred into action. We're also very conversant with the white paper that Robert refers to, which underpinned the reason why we really wanted to focus on assistive technology. I think the ultimate aim for us, it's probably quite a lofty one, but is really to enable people to remain within their homes for as long as they can, and also to help the residential care sector. And Claire's going to come on to some of the scenarios that we've chosen in a little while. But it's also about reducing the burden on the NHS, fundamentally. So we wanted to make sure that it wasn't a health and social care project, whilst predominantly it is, but we wanted to make sure that all aspects of the health sector benefited as much as within the scope of the project that we could. Next slide, please. Oh, sorry, go back one, I've just realised. So what are we actually going to do? Well, obviously it's on there, and colleagues will have probably had time to read the slides, so I don't propose to reread everything that's on that slide. But I think it's really important to note the fact that we have recognised that as much as we want to scenario base, build assistive technology spaces within our colleges, we also want to make sure that the workforce development and the curriculum development and the legacies that go with that are woven into the project. So existing qualifications within the care and health and care sector, we want to try and add modules to. We're talking to the CQC, we're talking to awarding organisations to make them, or to help them understand and to help us understand actually what's within the parameters of the project, what can we do in the immediate to short term, but also what can we do in the longer term to ensure that people are equipped with the confidence and the strategies to enable assistive technology to be much more prevalent in the health and social care setting. So we understand the digital capabilities and capacity of the workforce that's already in existence. Claire and I attended the Health and Care digital event a few weeks ago, and that was very clear to us. We're very aware of where we're starting from, but we're also very aware of the early adopters. So it's this real balancing act between making sure we're not patronising the workforce, but making sure that we take everybody along with us at the same time. So we've got strands of lower level. The LSIF is predominantly focused at levels 3 and above, but we understand we need to galvanise people at the level 2 in the entrance into the workforce. We know that with our own students and the work that we're doing on T-levels and the virtual wards and all those other things, we want to add assistive technology modules within that so that people are confident that people entering the workforce are actually already early adopters and they're not having to kind of change that culture. But we're also aware that there's a huge cultural alignment that needs to happen, and so we're very mindful of making sure that the leaders and managers within the sector are equipped to be able to do that. And yes, we know that there's existing digital frameworks already exist, and we're very respectful of those. So we're seeking out working very closely with Skills for Care as well, making sure that we might need to modulise things where possible so that people can be more adaptable and kind of train on things more quickly. So yeah, so there's an awful lot going on behind the scenes at the moment. We're galvanised. We're working very closely with North Kent and Mid Kent colleges. We're looking at our curriculum offer, and I think it's really important now that I hand over to Claire to give you a sense of the sorts of things that we're looking at in terms of those scenarios. You are now.
I'm on now, thank you. What I'd like to do is really to give you an overview of what this might look like in practice. So in each of the colleges, we're going to have digital assisted technology rooms, and that will be very much for upskilling the future workforce, i.e. our students who are currently with us, but also the existing workforce who are out there in care and clinical settings at the moment. And in consultation with some of our local partners, we have two proposed training scenarios, and these are just two scenarios. We do envisage this growing as we become more familiar and we go out to the care sector and say, what do you need training on? But the two examples that were very much came from our partners, we're looking at allowing people with early stage dementia to remain independent for longer, so to remain in their homes. So it was very much looking at sort of technology to allow them to do that. So that would be perhaps one of our training scenarios that we would use. And the sorts of things that we needed to be aware of is how to ensure that the environment remains safe for them at all times, within the home and also outside of the home. So in a moment, I'll talk to you about some of the technology. So one of the scenarios is very much remaining at home with someone diagnosed with early stage dementia. But also we looked at a residential care setting and how actually to allow residents within those settings to themselves remain independent within that setting, and also reducing so that they have more control. Rather than relying on support staff within there, looking at how technology can support them to do that. So that's very much one of our other scenarios that we were looking at. So if we can go on to the next slide, please. So some of the technologies you'll be very aware of already. For example, you've got the Alexa bot there. And we already know that Alexa can control lots of our household things, you know, sort of heating, lighting, etc. And it's very much introducing that would be one of the assisted technologies that we would use, but making people more aware of actually how this artificial intelligence can expand and be used really productively. Other things that we could look at is something called assisted technology. So again, it's either in a residential care home or someone who is remaining at home using sensors and pressure pads to monitor sort of unusual activity, unusual movement. So that if something is an alarm, if someone did fall, an alarm would be triggered, and that would allow sort of earlier intervention. And if we have earlier intervention, there's research shows there's less likelihood of them a client ending up in hospital, because they can be got to at an earlier stage, really. So it's using those sorts of technologies as well. Other things that we could use are sort of similar to iPads, but interactive, where a client could have a consultation with a doctor through assisted technology. And actually some of the assisted technologies, for example, could measure hydration levels. If there have been changes in sort of all sorts of things with the individual. So rather than having to go to the doctor, the GP coming to them, it could be done through AI. So the possibilities are actually boundless. And actually what we're talking about now could be very different in 5 years' time. So it's very much embracing that. So it's the workforce embracing this, as well as our care providers, because it really can make a huge difference. For example, going back to Alexa, one of the things with dementia is Alexa could provide nudges. And nudges can be as simple as reminding someone to take a shower or to have a drink because they haven't had a drink or to take their medication. So the technologies can be quite complex, but they can also be quite simple, and it's sort of embracing all of those. In terms of some of the feedback we get is families wanting to be involved. And again, technology can allow the sharing of sort of a doctor's appointments. If there is something happening, it's allowing that sort of holistic care. Rather than one individual having to ring and say, this is happening, those plans are available to everyone, instantly. So that this is the sort of technology that we are planning to introduce to start with. One of the other technologies that we are going to explore is the use of something called a paraseal, which is if you imagine a baby seal. It's artificial intelligence. But what research has shown that someone with, for example, someone perhaps with dementia becomes a carer. It's something to focus on, it reacts to their moods, etc. And it's found to be very, very calming, and it's a real focus. So again, it's exploring those technologies. And as much for our workforce to raise their awareness and for them to have technology, be confident in using that technology, as much as sort of, allowing clients to have more independence in their own homes, to have more control of their lives for longer. And I think that's very much why we want to embrace technology. But technology for all of us, it moves so rapidly. So a lot of what we're trying to do is through our rooms is to introduce the technologies to our future workforces, but to our new workforces as well, current workforces, so they become more confident. And as technology, if you have that confidence, as technology advances, people are more likely to embrace it and find it easier to embrace. So it's going back to changing the culture, the mindset, as well as really sort of bringing these into the work environment. And actually, and technology doesn't replace people, but what it does, it allows people to spend real quality time with others, and I think that's very much where we are, where technology can really help us. So, Robert said putting technology into people's hands, and I think both from, it benefits both the service user and the carer. So that's very much what we are looking to do. And like I said, it's sort of, as we become more aware and as technology advances, we will then be able to move with it because we have the environment in which to do that. Thank you. Thanks to you.
I think it's back to me now. Could I have the next slide, please? I think we're nearly there. So yeah, thanks Claire. I think you've very well articulated the 6 demonstration, when I get my words in, across the Kent and Medway colleges. So these will be both at East Kent College Group, Mid Kent College and at North Kent, where these scenarios are going to be. They'll probably be localised depending on what's happening within those particular communities, but I think we felt that the scenarios that we just outlined are probably those that most need and those most prevalent. It also includes creation of digital care planning. We recognise there's obviously a whole infrastructure piece that needs to go alongside this. Again, I'm not going to read what's on the slides. You can read that for yourselves. But just in terms of some key milestones for us. So we're looking at the bottom, it says a sector collaboration event. We've already got that penciled in for, I think it's the 22nd of February, have we, Jonathan? Yeah, 24. And that we see very much as a continuum of the digital health and social care event that I just briefly spoke about that happened a few weeks ago. We felt it was really important to recognise and to understand actually what was in scope for that conference, to make sure that there wasn't duplication of effort, and to make sure that we understood where providers were in their digital journey, and an awful lot of other things that I've already talked about around CPD, and a campaign that's showcasing and promoting the sector. I think the other thing that's probably not on that slide is we've also engaged an IAG bus, for want of a better word. So we've got a double-decker bus that's going to be coming around to the communities. It's going to be showcasing all 3 projects, actually, because we've also got an engineering construction project that's happening as well. But just to make sure that we can mobilise and raise the profile of the project, probably in a little bit more of an innovative way than's probably happened in the past. So I'm rabbiting on now. There's lots happening. We're very excited. And I presume we're going to be opening up to any questions. We know. Thank you.
No, let's have a discussion.
Great. Well, thank you very much, Lindsay and Claire and Jonathan and obviously Robert. That's really helpful. I'm very excited about this, especially the opportunity to use the training facilities across the care sector and across all of our partners. And I think there's a lot of nodding around the table, because as much as we need to train the future workforce, and people will know, that's always something I'm very interested in, having had a long career in further and higher education, but our existing workforce. And I think for partners around the table, the issue is that assistive technology should be part of care packages now. It should be part of adaptations that we make to people's homes, but it isn't, not really. Not to anything like the extent that it could. And part of that is because there's a training and education gaps. So the ability of the project to share your facilities is fantastic. And I'm sure that we'll be hearing from around the table how we might do that. And certainly, I'd like to know how we'd get our workforce along. And I think in particular, it's about confidence. Confidence of the workforce to know that if they're recommending assistive tech, it will work, and confidence of the recipients that they will be able to use it. And where I've seen around the country areas that have really focused on this, that there's no doubt that the feedback is that people not just staying in their homes for longer, but being independent for longer and taking control of their own care is very attractive in a modern setting. It isn't everybody that wants people coming into their home. And as you've said, for those who are coming into the home, then the time that's spent with a lovely human face is better quality time. And I think there's a huge area as well of personal health monitoring that plays into assistive technology. But we've got to think collectively, as I always want the Health and Wellbeing Board to do, what contribution can we make around the table to making this happen? So apart from your questions, I'm really interested to hear your views on how we do that. And I'm very pleased with you here, Claire, from MVA today, because there's a big role of education for our voluntary sector to do, and to involve you in the kind of rolling out of these possibilities. So with that, I'm going to open it up to questions. And Eddie, I saw your hand.
Thank you, Chair. I don't normally get excited about things to do with tech, I must admit, but this is a very exciting idea. Anything that can enhance a joined-up technical system within health service is badly needed, as I found out again when talking to a health practitioner today, and they didn't have access to my medical records. More than once, there's been reference to cultural resistance, and I'm just wondering, that interesting word cultural, are we referring to the usual, oh, I don't like change, reactionary type of mentality? Is that what you mean? I'm afraid I have 4 questions. The second one is even though this technology is free to Medway, will there be a cost to practices? Because as we know, they are businessmen as well. Third one, will this promote more telephone diagnosis? Because I know it's not just about the healthcare sector, but presumably it's tapping into that, and therefore less one-to-one contact, because it has been documented where that has been vital. And the fourth one is the classic, will it lead to any loss of jobs at all, please? Thank you.
Yeah, I'll take perhaps one. In terms of the culture, what we do find, and I say this as someone who started their career as a care worker, do find in the sector there is an aversion to technology. People will say, I'm not very technology minded. You know how we say, I'm not very good at maths, you know, and it's okay. Well, actually, you know, we've all got these. And, you know, both the patients and the staff today, you know, they'll be using this equipment. And so it's about sort of what we can do as colleges to provide people with the confidence and the familiarity to be able to, you know, be aware of the functionality of technology that is, you know, fairly straightforward, but because it's new and it's not perhaps every day, then people will say, you know, there's a culture of I don't do technology. In terms of the costs and staff time, I mean, I think it's a very important point in terms of how we get funded with qualifications. Do you want to pick that point up?
I think there's there's probably a few things, and I probably should have mentioned it when I was presenting actually, but we're very mindful of one of the barriers that's come through loud and clear is the cost of obviously the technology, not least for those people who have actually been early adopters, because a lot of the innovation funding that's around at the moment is to enable those that are still, you know, lagging behind, for want of a better word, to avail. We, yes, obviously have funding through our adult education budget and through this project. But I think what we're also really mindful of in terms of the wider scope of the project is making sure we can signpost providers to where those pots of money exist. Because certainly Skills for Care, there's a digital transformation fund that's having their first wave. So I think it's about signposting. And I think it's about us complementing through some of the digital and Innovate UK projects, of which we have bid for, and I'm also looking for an innovation group head of innovation aligned to the health and care sector that's brand new, it's going out hot off the press today. We're mindful of making sure that we I keep talking about this legacy thing, don't I? But we don't want the project just to be a sharp burst of intervention. I think it's really important that we make sure wherever we can that we are working together, and the needs of the health and care sector aren't going away. So I think, yeah, it's a very kind of convoluted answer, but I think we always have in our minds, if there's pots of money, we want to make sure we're continuing the work that we've already done. Because don't forget, obviously, there's quite a lot of investment that's happening within the colleges, and the last thing we want is for them to be white elephants as well. So I think it's about equipping the workforce to give them the information to know where they can avail of funding, making sure wherever we can that we provide adult education budget and all those other things and complement the provision and the curriculum change. And keep bidding for more money ourselves.
That's reassuring, sorry.
Just a small point on this, and perhaps it's, you know, Robert might want to comment, because I think it's an absolutely crucial point, Councillor. This is a two-year project,
yeah. And
so the final point that I said that we want to influence in terms of the policy and the funding, you know, we know that funding is available, you know, within constraints. And we know that there's devolution coming in terms of adult skills. We saw from the autumn statement yesterday, Tier 2, which no mayor, so that might mean that we might think about that. But if we can imagine in a few years' time, there is more flexibility around funding. And so we can influence that by doing the research with Robert, making sure that we've got good relationships through Policy Connect with the department, so they understand on a scale, because this hasn't been done on a scale. As I said, Robert said it's bits of equipment here and there across the country. We've got 1.7 million people across Kent and Medway, and so there'll be a lot of interest in terms of really, and so we'll be able to say, well, we've done this within our pilot money. It's come to an end because the constraints of the funding regime don't allow us to continue, and that can then influence policy. I don't know if you wanted to add to that, Robert, because that's a really important point. Yeah. So it isn't here today and can't do tomorrow, Eddie. I think that's absolutely crucial.
Yeah, absolutely. And I think just to say that what we've heard directly from policymakers, that this is the kind of evidence that they're crying out for, really, because what they do get over and over again is these very, very small scale pilots, as Jonathan said, focused around a piece of technology that might be great, but it also might be obsolete in a while. So having something that really does look at the system, in this case the crucial skills, awareness, culture part of the system, is primed for influencing decision making, and frankly kind of rides a wave of greater interest in technology within care and within disability in general. So, for example, we may see coming out of the Disability Action Plan, there's proposals for a national champion for ATEC, and as national government starts to put things in place like that, these are kind of hooks that we can get into if we have the right data and evidence behind us. Yeah. Oh. You had a question about jobs as well.
Yeah, jobs and encouraging even more lack of one-to-one.
Yeah. I'll just say something about the jobs part. I'm not an expert in this myself, but obviously speak with people who've looked at it. I think what's happened is that some technology developers have looked, in trying to make the case for the kind of return on investment from their product, they've tried to show that you'll make money because it will reduce the need for care. And that's a sort of an obvious way when you have an innovation to try to show that it's going to be return on investment. What I've heard is that the evidence for that is actually not that strong, and that the real return on investment is from better outcomes, people not going to hospital so much and just in general having better health outcomes. It's a narrative that we have to understand is quite strong, and it plays into the cultural piece and people's fear around the technology. But I think the origin of it is less based in reality than it's based in some kind of perhaps well-intentioned but ultimately backfiring attempts to show return on investment that haven't really done that.
Thank you, Chair. I'm Jim Morby, and I'm the Exec Director at Kent College for Curriculum. I'm actually leading a work stream on behalf of the college, which this is one project, with the NHS in general. So a lot of different projects that we're doing, which Jonathan has been instrumental in, Lindsay and Claire are heavily involved in that. But just to pick up on a couple of those points, first thing around the funding for that, there is a big change coming to adult funding in 2025, which will enable us to continue to fund skills development within the existing workforce much more easily, and we can do much more modular provision than we've been able to in the past. So there's a big opportunity for us to develop programs around, training programs around the use of whatever we want, assisted technology in this case. The other thing just to say around jobs, and this is really just from talking to the NHS and the sector there, is that the needs for care are growing and growing and growing. And we can't fill those jobs, and we can't sort of respond to the employer needs. So actually developing things that will help that and lessen the sort of burden on the NHS itself, rather than sort of replacing people, will just help those people to cope with the level of care needed. So that's the sort of story really that when we're looking at we're interested on two parts. One on sort of upskilling and training adults and professionals in that field, but also, as Claire and Lindsay mentioned, young people coming into work in that sector and finding the right jobs and those being doable jobs and sustainable jobs within that sector.
What's ringing in my head is there was on a programme very recently, a GP, and as you know, a lot of the GPs, they run out of business, and he actually admitted that as they lose staff, they're not replacing them. Why? Because after 5 years of not getting a pay rise, they're taking that money from their budget and paying themselves rather than replacing staff. So I've got that in my background when I'm talking about this. However, what's really, really reassuring are your answers. The idea that you're going to support and try and help funding streams, and also that you're obviously here in the long term and it's a joined up relationship. So I think it is exciting and very positive, so thank you.
Thank you, Chair. Thank you for your presentation, and it's great to see that we're going to get in the colleges this technology room with all the technology for assistance, etc. And it's going to be geared toward the workforce and training new workforce and existing workforce. However, it might be just my personal experience, but normally the first carers with someone with dementia are the close family before ever anybody gets introduced from social services or wherever to come and help. And assistant technology, we have a close family member that dementia still lives at home, and we've been through that journey. We've installed Hive so we can control the heat. We've installed an Alexa so we can nudge to take a drink. We've installed an Echo so we can see them without them having to answer him. We've put a Ring doorbell in to see whether they've wandered off or there's some unscrupulous person. So we've been through that journey, but we didn't have anywhere to go to find out what was available and how to implement it and how we can do it. And I wonder if in part of your thinking you're going to be opening up your room to just general members of the public, families that have got people in that same scenario, so they can come and visit on a Tuesday evening or see a demonstration or something like that. Nothing to do with the students, but to help families that are often the first carers. Thank you.
Without getting into too much detail, I completely understand too. My mum had vascular dementia, so I've completely lived what your experience is. Probably why we're so passionate about this project as well. And I think that's a cracking idea, I have to say. I think bringing people more into the community, and that's probably the community aspect, in which again needs to be another strand to this project. I don't know if Claire wants to say something. I think it's definitely something we probably want to do.
No, I absolutely agree, and this is very much a community project, and it's raising awareness, because the more people that are aware, the better. And with early onset, Councillor Hackwell, you were talking about, you put in those technologies, but there's lots of people that won't even know that they can use them in those ways. So it is supporting from right from the start. And of course, in all of our colleges, we have lots of footfall. We're open all the time, and I see no issue with adding that into our project at all.
Yeah, really good.
Yeah.
Thank you. Thank you for the presentation. It is really exciting to hear what you're proposing. I think one of the things for me would be about things change very quickly, and you said that. And certainly for quite a number of stakeholders, even for my organisation, we're developing our clinical strategy, for example, and therefore it seems sensible to tie in some of the proposals and things that you're talking about. Just a question then, so how over the next couple of years are you going to continue to keep that stakeholder engagement? Because as things start to change, you're going to have to move with it as well as the organisations themselves. So I just wondered how you had thought about that.
Going to say something? Go on, you go first.
I think we are very aware of how quickly technology changes, and I think with the scenarios particularly, that they're set up in a way that we can move with technology. So nothing is, the environment is not a fixed environment in our training scenarios, etc. And also it's responding to what the demand is. So we have obviously met and we've proposed these training scenarios, but actually other more demanding, different, something we haven't considered might come along, and technology actually allows us to embrace that more quickly. And I think what all colleges, all of us, we work really very closely with organisations like Kicker, Skills for Care, the NHS. So, and that's very important that we have stakeholder engagement, because they're our specialists. They very much drive where we're coming from. And I think throughout this project, we have our, our sort of key people that we are, and we will bring more people into that. So, and I think the way that colleges and education is, we have to be open-minded to what comes on. So, it won't, and so I suppose what I'm saying, I don't know if I'm answering your question, but we will move with the technology, and this will allow us to do that as well, this environment.
Thank you. Just to add to that, it's one of our strategic priorities in all the colleges that the resources that we offer are current and up to date, so that students can learn on things that, if they're not top of the industry standard, they are at least sort of current in that. So we're always looking for, and as Lindsay mentioned, this is one of many actual bids that we've put in around different resources in different sectors, but it's really, really high up on our agenda. So we're always looking at, and over the last sort of 5 years, we could tell you about the different technologies and things that we've bought for health and social care and students going through that route. So we'll keep doing it. The other thing just to mention is the work that we're doing with the NHS isn't a finite work. This is a sort of long-term relationship in terms of thinking about that pipeline and growing those skills in students in order to meet the current and future needs within that sector.
Yeah, a quick one from me on staying up to date with the technology. One of the things we learned from the report Frontline Accessibility that I showed, which surveyed various training programs for frontline workers in different sectors on ATEC, is that frontliners really appreciated having specific tips with specific pieces of technology. So I think that's the strength of this program, that sometimes in response to the very real fact that technology changes quickly, people have designed trainings that are just trying to sort of train people on the principles, and it actually gets very abstract and people don't quite know how to apply it. And so even though what you might have trained on 5 years ago, you're not going to be using the exact same thing, actually it's by getting hands on something tangible, using it now, and then continuing to update gradually that we've found people report that they respond to that.
Thanks. I think the only other thing I wanted to add was that I know that there's a care sector digital group that happens, and I think that they were just looking for longevity and sustainability with that. So it is definitely something we, again, it's not a specific KPI, but it's something that we're aware of in terms of being able to continue that group to meet really and accommodate them, because obviously it will be invaluable to us as well.
Thank you, Lindsay. Before I come to the next speaker, Jane's point about the hospital wanting to work this into their clinical strategy, I don't think we would have heard that if you hadn't come along today. It's really important. And similarly, from the council's point of view, where we do the home from hospital partnership work, bringing people out of hospital as quickly as we can, it's something that, needs to really be a central plank. So some perhaps further discussion outside of the meeting on that, I think, would be very, very helpful, please. Right, next person, Martin, please.
Thank you, and thanks for the presentation. We, as a community provider of health services, we use a lot of this tech already. So I suppose my point is come back to Jane's point, is how do we keep up to date and speed of this? And it's not usually the system and the functionality of the particular system that falls down or the training, it's the interoperability with other systems. So I suppose I really value a discussion out of here how we move that forward, because going back to one of the previous questions around patient records, if this doesn't feed into the electronic patient record, then there's another system. And we're always relying on the interoperability of building APIs across to bridge that. So I'd really be keen to pick some of that up. And as Jane said, as a system, we're looking at a clinical strategy and a digital strategy. So again, probably not for here, but outside, who in the NHS you're talking to, because going back to one of the slides, really keen that we have the co-design between the patients, the residents and the clinicians. And again, it picks up some of these issues because the sensors, they're paramount. They really help us in providing care, but it's not the only answer, as you've stated. But I'd just be keen to pick some of this up. Jonathan, you've obviously got my details, but I'd just be keen to take this outside really, because there's a number of questions on this going into some detail, I suppose.
Thank you. And echoing really what Martin said, probably really helpful to take some of this outside of this meeting. But full disclosure, I used to work for Medway Council's assistive technology, so I'm a bit of a convert already. A couple of things from me, really. Firstly, I think the sector's got something really to add to this, so I'd love to explore what the programme could do in terms of connecting in with that. I think certainly people are complex, and it's not just about assistive technology and that sort of holistic offer and thinking about, you know, carers, befriending, all of that, so sort of really adding value where I think could make a real difference for people. And secondly, around that kind of resistance to change, it's not just the professionals, although there is an element of that, it's also you know, the people involved. And two things, I think the sector can be persuasive in terms of breaking down those barriers because we're working often with some of the most vulnerable. But also, if you want to kind of understand a little bit more and if you want to do a bit of research around that, perhaps we can sort of explore that as well in terms of understanding what those barriers are so that we can then address them. And then this one's a bit more of a techie question, really, whether there's capacity within this programme to also think about the people that respond to the assistive technology, because from my experience back in the day, one of the biggest barriers when I think about hospital discharge and prevention, the technology's there, but often you need somebody to respond to that. And I know back in the day we had to turn people away because there wasn't somebody to respond, or it becomes the ambulance or the police that get called out, and that becomes a false economy if we're thinking about the whole system. So I wonder whether there's some capacity to factor that in. You know, how do we find the people to respond if they don't have wonderful family to be able to do that?
Just a very quick response, because obviously, as you say, it's probably a wider conversation. In working up some of the costings and the supplier base, we were very aware of the infrastructure that needed to be aligned, not just putting tech in and there you go, off you go, but also the support packages that go alongside that on a licence basis. So, but we probably need to go into a bit more detail just to reassure you on that, both those points. Go on, Robert, you wanted to say something?
Yeah, I think it's worth noting, especially in relation to the technology that, you know, the alarm-based technology that you refer to in terms of, you know, if somebody falls where people are called, that of course that is moving from an analog system based on the landline to a digital system. So that's again one of the ways in which this will kind of bring us up to date.
Just in terms of the, you know, sharing all this information and joining up, you know, we have the healthcare partnership, and, you know, from our observation as colleges working across Kent and Medway, they are at varying different levels of maturity. And so, you know, perhaps that's the right place, because, you know, there has an educational feature there, and it's not just health, it's care as well. So perhaps that's the forum that we talk about, and I think that your encouragement from that, Chair, as this organisation would be very helpful. As I say, there are different stages of maturity.
Thank you, Chair. Thank you for the invitation. Your presentation was fascinating, actually really exciting. I'm relatively new to Kindy. My previous life was in health and social care in the third sector. And there's a lot of stuff that you're talking about doing that we are also looking at. And again, for a conversation outside of here, I think it'd be really interesting to have that conversation. Things like the sensor-based, we've started that project. We've rolled out a lot of assistive technology around sensor-based care recently. And I think it's really important for everybody, we go back to barriers, is building that trust in what the assistive technology can do. And that's one of the things that we're currently working on, is that data to be able to feed back to prove the concept. But I think it's really interesting to be able to work potentially with you around our current workforce and showing that data. So really it was a comment to say it's really exciting, but I'd really like to have further conversations with you. And Claire also said quite a lot of stuff that I would have covered. It's fine. In that we passionately believe as an organisation that everybody's care is different. People are individuals, so we are working quite closely with MVA, who I know, and other organisations, because assistive tech is a really important part of the jigsaw, but it really is a part of a jigsaw that needs input from other places too. Thank you.
Thank you. Two brief questions, if I may, Chair. The first one's just really to help me to understand what I think is going to be a really positive impact, and really welcome the presentation, so thank you for that. Are there any specific metrics that you'll be looking at to determine success for the project? So are you targeting a particular number of people who you're hoping will be able to remain in their homes because of the technology, who otherwise wouldn't have been able to, or a set number of workers that you're hoping to upskill? Because I think that'd be really, really useful for us to know. And then the second question, I think maybe is a little bit more towards Robert, just to help me to understand. Obviously, this sounds like a very good thing to be doing in and of itself, but I am very conscious of the financial environment that we're all operating in. And I'm just wondering, at a broader level, are there expectations for how much money can be saved from the NHS budget or the care budgets by rolling this out more broadly? I think it speaks to some of the earlier discussion around, if we look at this kind of thing as a pilot, getting the evidence base to really assess, whether it's something we want to be doing more widely. Do we have any, at a national level or more locally, an understanding of the potential cost savings that might be generated by this great technology?
I have a table of KPIs in front of me in anticipation of that very question. And they go on a bit, so I don't profess to go through all of them, but just to reassure you that obviously by working up the project we have to have impact measures, and it's something that we're very focused on. They range from number of new courses, to people availing of the curriculum, to workforce development, to employers visiting the spaces, to actually there is a line on anticipated savings, not just through optimisation of services, but through the collaboration between the colleges as well. So maybe that's just something that I could share after this meeting, so that colleagues are aware of the things that we will definitely be measured on, because that's what we're all about. So.
Thank you. And just before the next speaker, Vincent, something that I've been very interested in and continue to be interested in working with staff on is this ability to show cash-based savings in a people-centred environment. And obviously, one of the things that has to change is the way that we do our budgeting, because we need to be looking longer term at the way investment eventually, prevents a number of people going into the acute hospital, prevents a number of people going into residential care. And James is doing some modelling for us actually on falls. And I think, James, you've got when we've had the speakers, James would like to just come in and sort of tail end that. So just for everyone's information, I'm going to take two more speakers, Vincent and Leanne. I'm going to ask James to come in just to sort of wrap things up from the council's point of view, because there's been a really, really, fruitful discussion, and it's, clear that there's so much we can be doing outside of the board, which is great. But I'm mindful that we've got lots of other items. So when James has said his piece, then I'm going to take a natural break. Those who want to leave, please do so. If you'd like to stay, you'd be very welcome. There's a few refreshments for everybody, and then we'll start the other items, which means that we'll be a little bit longer than we normally are. But that's fine, because this is time well spent. So, Vincent.
Thank you, Chair. And I hope I'm not going to steal James's thunder, because, excuse me, really welcome the presentation. I'm from NHS Kent and Medway Integrated Care Board, so part of our responsibility is around providing leadership to the NHS across Kent and Medway, but we're also working with Medway Council and Kent County Council in terms of the leadership of the integrated care system. So my offer really is about how we link this work into the paper we're going to be looking at slightly later on, which is about our integrated care strategy. And one of our shared outcomes is about how we support and grow our workforce. And this absolutely sits well within that domain, but also just recognising the complexity of the system across Kent and Medway, and obviously navigating all the different organisations and people that you would need to speak to. And really it's an offer because the ICB has a role there around digital transformation, our people strategy for the system and creating that connection, but also that piece about how we ensure that we integrate this into some of the transformation programs that we're working on at a place level. And I could absolutely see the connection here to the work we're all doing on integrated neighbourhood teams, how we work with primary care and our primary care training hubs. So again, I'm raising those points because it's that piece about moving from a pilot to sharing the learning and then integrating into a sustainable approach. And we absolutely want to work with you on that.
Thanks, Chair. My question's around the private sector because there's not too many interfaces with adult social care, etc., around that interface with the private sector. I would have said this would have been an area that the private sector would have jumped at. So my question is around that, and just if you could explain, because I think waiting for public funds is going to be a long wait. So we need to think differently there. But I just wanted to preface, because this is really, really exciting, the use of assisted technology around health and well-being is we are only limited by the extent of our own imagination, really. Probably, if we were sitting here in 100 years, we'd be thinking, why are you having this conversation, because things would have moved on. But I wondered how much we are limited by our own imagination, because I've been sitting here thinking there are some key issues in Medway, and I saw Jane to my right and I thought, corridors. How could assisted technology help with the issue of corridors in the hospital? And then I thought, well, maybe we need to have a technology-assisted antechamber, not a corridor, something else. But we're limited, I think, to a large extent by our own imagination around the health and well-being use of technology. So I'm really, really pleased that you've come today. But could you just elaborate a little bit more on the possibilities of that link with the private sector?
Shall I start with that one? First of all, and we don't interact with the private sector, we work in further education. But in seriousness, I think it's a really interesting idea. It's not really something that we've been working predominantly with, what's going on in the sort of public health sector in that, but certainly really happy to explore it. And if there are sort of, ideas or people we put us in touch with, then absolutely we'd be interested in talking to them, I think, around that. But it has been predominantly the work focused in the partnerships and the care, and particularly, similarly with kind of community groups and so on as well. But I do think it's an interesting idea that we probably need to think a bit more about, really, and come back to you on that one.
Leanne, do you mean the private sector in terms of care providers? Or do you mean the private sector in terms of technology?
I mean in terms of what the limits of or the possibilities around assisted technology that I think would be very, very interesting to the private sector. We, in terms of health and well-being and our day-to-day jobs around the care sector, the acutes, whatever, my point was we are limited, I guess, to the extent of our imagination, but the private sector in terms of assisted technology, I think, may help that.
Robert, that's probably your best place.
Yeah, I'm happy to come in. I think one of the things that I've talked about looking to share the results of this work with national policymakers and with other local areas, but another place that we want to share with is the tech sector. So we work quite closely with Microsoft, with Google, some of the other kind of big tech firms, and for them to understand how their technology needs to serve as a platform and integrate with more specialist tools, who their users really are in terms of the different professionals who are using it, and they are looking for kind of collaborations that have real-world impact as well, so they could potentially play part of the role of sort of follow on from this project.
Yeah, just before I bring James in, I think as well, you know, Jonathan, quite right, obviously people that we commission to do the council's work are in the private sector. So we do need care providers to be sending their staff along, particularly domiciliary carers, to get this training and to show awareness. And I think the other sector that, you know, definitely ought to be involved is construction. Because when we're thinking about extra care housing, lifetime housing, different ways for building for different parts of the community along the kind of life cycle, then, you know, we ought to be building in this kind of technology. I would like to see that in new homes, and at a time when we're just consulting on our local plan, that's something I think that we need to be sending a message to developers, a very strong message about.
That bit we are doing.
Okay.
So we're doing a lot of work, and some of the other projects that we've had through LSIP and LSIF funding has been around construction sector retrofit stuff, but also, you know, we're looking at things like, you know, the same kinds of technologies around lighting and things in housing, and our electrical students are getting a whole load of kit to do with that. So yeah, we're joining up in that kind of context.
Helpful, and I know that's your background, Jim, so that's good for you to be there, bigging that up for the college.
Thanks, Chair. And actually, I had a few points, but as we were going around, a lot of colleagues picked up the areas, particularly Councillor Edwards, because it was about the outcomes and how do we actually quantify this work, because it's huge, and we've got to be really clear that you can't boil the ocean. Well, you can, but it'll take you a long time. So I think Vincent referenced, and he did, to be fair, the context of embedding this into the way forward that we're actually already in the process of trying to create. So then we're not reinventing wheels, we're not trying to retrofit or come in laterally. So I think that point that Vincent referenced around the integrated care strategy and that broader system, because this work is really smack bang in the middle of it. I think Jane's points around how do we practically use these tools is mission critical, and it goes back to Leanne as well, because it is about the people that we're trying to work with, the population. Councillor Hackwood mentioned he's already gone out there and spent a load of stuff, and it worked in various ways. So we've got to do a huge cultural change, because this stuff isn't a panacea for everything, which means that we've got to be really clear about prioritisation and in the areas to measure our inputs and also our outcomes. And I've got down here inequalities, because we recognise that a lot of folk that would really benefit from this way of working are potentially not the ones that are currently thinking about it or able to utilise that resource. I think that's Leanne's point about where do we get the additional, you know, impetus from other bits of the system to support that inequality slant. I've done a bit of somebody mentioned prevention as well. So ultimately, what we've got to really try and do, I mean, most people in this room are wearing wearable tech. What does that mean? I generally don't know, but it's these smartwatches and all the other kind of stuff. But if we'd have been speaking about this concept a few years ago, none of us would have been wearing these types of smartwatches and things. So what are we doing for the people who aren't already known to us? And how do we utilise those other avenues to build into the way in which we do things around here, accessing this type of stuff? One big ticket item is the Kent Medway care record. Because I was in a workshop yesterday, a system-wide one, where we were looking at frailty. Now, frailty is just a term, but it's, you know, let's call it wellness and people losing that as we get older. So there is an opportunity for us, because why am I saying that? Because that system is risk stratifying and identifying people who are not actually in the system at the moment, but will be through a whole range of putting things together. So that comes back to a point that was made, I think it was our kindy colleagues were making that about how do we harness, and Martin, how do we make sure that we capture all of the stuff that we're doing, because that will then give us the ability to determine whether we've actually made a difference in the end point. So I think it's really exciting, Chair. I think there's so much that we've discussed today, and this, I think, is the benefit of having this board in the form that it is, because we're trying to solution things and find ways to collaborate rather than to identify things that aren't going so well. So thanks, Chair.
I think that's a really positive note to end on, and I do thank you ever so much for coming, and I'm really pleased that I asked you to come, because I could see very clearly that we needed to widen everybody's knowledge about what you're doing, because this is a very relevant group of people who need to understand that. And also to showcase it, because, I feel very proud that we've got that funding coming into Kent and Medway. And I think, outside of care, we've already seen today that there's the potential for jobs in technology itself, in construction, in other things that are related to this. So this is, I hope, a real kind of seed corn for sustainable new skills, as well as improving the lives of people in Medway. We've given you rather a lot to do, I feel, and it might be sensible for Stephanie and I to work together and think about the things that have been agreed and suggested that we do, for two reasons. First of all, so that we don't overwhelm you, and secondly, that we do actually do them. And put people together in the way that they've asked. So perhaps if Stephanie and I have a look at what we think we've said, and then come to Jonathan to verify that, and then work from there, because certainly working through the Health and Care Partnership does, that is the most obvious place to start to get some of these going. But I think I'm very mindful, Martin, of what you said about making sure that the systems within our kind of technological sphere speak to each other. So you're very welcome to a cup of tea and a cake. You're very welcome to stay. I'm going to stop at that point when Eddie's had his say again. And then, perhaps have 10 minutes and then come back to the rest of the agenda. So thank you for coming, and I really appreciate it.
Thank you.
Yes, Eddie.
I just want to know whether we're going to get a further report, because we'd love to hear the progress.
We'll certainly, either through this board or other ways through our work with the ICB, follow this up, because, I'm conscious that you're not waiting for us to tell you what to do. You're moving all the time and working on this. But, it's a great piece of work. Well done for the bids, and best of luck. And if we can, certainly support any other bid that you're making, very, very happy to lend the council's weight towards doing that. Yes, James.
Just to confirm, I think what the offer was from Vincent is the bit to embed the principles and what you're doing within the wider architecture that we're using for the integrated care system. There's lots of committees and things that you need to get involved in that space. I think it's probably outside of this meeting just to dovetail the detail into how that happens.
Yeah, anyway, thank you very much.
Thank you. Thank you. Thank you, everyone.
Thank you.
I can see her pointing. Okay, so the Health and Wellbeing Board is asked to note the proposed project activities that have been stated in the report, which is related to the successful bid now. I just picked up also just to work with key stakeholders as technology and organisational strategies develop across the sectors, and to link into the integrated care strategy for Kent and Medway.
Thank you.
Really good. Well done.
they're being managed in a different way, and they're managing themselves in a very different way. And I think the logic model will be really critical. Actually, Jane, as you mentioned that, I think it'd be helpful for some of your colleagues just to take sight of that, because at a system level we had a really good discussion this afternoon actually with Vincent chairing a group earlier on around these measures, but I do think we just need to make sure that we sense check that so everyone feels that they're actually seeing what they would expect to see from the work that we're doing collectively.
Eddie?
Thank you, Chair. I don't know if I'm being slow with something like this. Often, I read a lot of politics, I'm weird like that, and you always read these statements like, oh, this has gone down, you know, poverty's on the level of poverty is increased and blah, blah, blah. And I always wonder when those statements are made, how specifically that is measured. So, for instance, on here, something like improved outcomes for disadvantaged groups, how do you know that? How do you know that there is an improvement in the outcome for a disadvantaged group? Now, I know surveys are done, but how else do you actually get to the nuts and bolts and measuring and then making a bold statement? Please.
Thanks. Well, fortunately for us, we've already gone out there and we've talked to our population, so we physically do ask people, and we've got a wellbeing survey that David and his team look after. But that's exactly the point. The reason why we will know whether we've got a difference in terms of, you mentioned disadvantage there, because there's, so there's lots of ways in which we can look and triangulate that, but we're trying to be really systematic and use the same tools that we've actually gone out there and used to say, where are we now? So we've got a baseline, we do our interventions, and then we can come back and apply the same methodology to see whether there is a difference, so we can do that quite concretely. The bit about whether people feel different, an example of, well, I could, but what I'll do rather than doing that, perhaps David, do you want to describe very briefly, because we do it in lots of different ways. So I did say we ask people, so subjectively there is a way in which people may or may not feel that they're more able to do stuff, and that's what we do, and there are different scales and tools that we can actually utilise, but there are quite a few in order to see whether we've made a difference or not. But we actually use other mechanisms which are standardised, but we've done a Medway cut on that for ourselves, so that we've got more of a granular understanding as to what's happening in Medway than we would be by relying on national data sets that will generalise our findings. David will explain it really quickly, but I think probably what might be more helpful is to have an offline conversation where we can perhaps go into some of that detail to give you a bit more assurance. But David, you would talk about picture Medways.
Okay. Yes, what I'll do is I'll send you a link after the meeting where you can have a look at the data that we've collected. But as James said, we did a health and wellbeing survey of Medway. I'm not aware of any other local authority that's done something of a similar nature. We took a scientific approach, took a random sample of households across Medway, and then went and interviewed them. So we have a really detailed picture of health and wellbeing outcomes and risk factors across Medway. And we will be able to look in future surveys to see how things change. The best thing is if I send you a link to the products that we have online, so you can see some of the data we have already.
So just to try to make sure I understood this, it's mainly asking questions and then looking at those answers and comparing to previous answers. So it's surveys.
It's a combination. It's a combination of using hard data. So we know, for example, how many people are resident in Medway. We know of those people where they live, how disadvantaged that area may well be. We'll know how many of those people from those areas are attending, unfortunately, the ED department for issues that potentially could have been prevented or avoided. When we then start to pull into, our mix, as well as we've asked people about subjectively how they're feeling, we had the point around safeguarding and do people feel safe. We know how many young people from those areas are in our care. So we don't just try and use survey questions and answers. We try and use different ways to look at a problem or an issue and then figure out what that's actually telling us. But it's probably more helpful for us to have a conversation with you offline, and then we can go into that.
And if I can recommend to you, Eddie, if you look on the website and just tap in ward profiles, you'll see really detailed information of exactly the data that David's talking about. So we know how people are. We know where we've got clusters of older people. We know where we've got clusters of people who are suffering from respiratory disease. And you can look at that on a ward-by-ward basis. Certainly, a good place to start it is your own ward. And we're watching all the time with the measures and interventions going in to see how that data moves. And if it doesn't move, we're not getting something right. And I think we have to be very clear and very honest in admitting that in the last few years, it hasn't been moving quickly enough. So some of the things about asking people questions about the way that they're feeling in the way that David's described helps us to understand, well, what's not happening? Is it that people are not going to doctor's appointments? Is it that they're going to too many doctor's appointments? Is it that they're not, their medication isn't being reviewed properly? They're not taking advantage of other things they can do to maintain their own health and well-being? That survey questioning is really critical to illuminating what's behind that data. But it's the data that we have to use to see how things are moving on. And the ward profiles are accessible to anybody, and they're very current, and if I may say so, very interesting. Claire, please.
Thank you. It's just a quick point, actually, just building on Jane's point about feedback in terms of, you said, we've done. I think when I look at these themes, it strikes me there's going to need to be a really strong sense of ownership amongst communities to actually make these successful. So I think it's probably about more than just feeding back to the people that participated in it, actually getting the strong message out there saying we have gone out, we've listened, this is who we've engaged with, and this is what we're going to do as a result. So we sort of foster that sense of ownership.
More questions or comments? In that case, I'll go to Jane, please, for the recommendations again.
Thank you, Chair. So the members of the Health and Wellbeing Board are asked to note the development of the draft Joint Local Health and Wellbeing Strategy and to recommend engagement of partners in feedback and implementation, and also some further work with colleagues looking at the measures and outcomes.
Thank you. Is that agreed, everybody? Okay. Final item then is the work programme. I'll go to Stephanie for that. And thank you for your forbearance today. We've run over a bit, but that was intentional on my part because I really wanted to have a good go at the assistive technology item. So thank you, Steph.
I don't actually have anything to add to the work programme. I just take it as read.
Okay. So taking the work programme read and doing what I hope to do, and that is finishing on time at 4:30. Thank you, everyone, for your participation today. Yes, I will let you do that, Jane. Agree the work programme.
Oh, so I should. Please. Can I just ask that the committee agrees the work programme?
Thank you. You can see if Stephanie wasn't here, we'd keep coming back for all the things that I haven't done. But that's exactly what we've got her for. Anyway, thank you very much, everybody, and look forward to seeing you again. And we will collate those questions to the... Steph and I will work together on that to the team from Kent and Medway Further Education, so that we really get things put in place. And I spoke to Jonathan at the end about coming to the healthcare partnership, and we'll definitely do that. And I hope that's opened up dialogue, particularly for Kindy and so on through that item. Anyway, thank you, everyone.